Here is a waterfall plot which shows % change in tumor size from baseline across the patients that were evaluated in stratum A or stratum B, and the stars indicate patients with mutations in stratum A, and from what you can see here, 4 out of the 5 patients who had c-Met mutations had the greatest tumor shrinkage. So again, confirming that this compound works by the mechanism that it was shown to work in preclinical models. Here is a plot of progression-free survival. Again, stratum A seems to have a greater median progression-free survival than stratum B. These data were also not fully evaluated at the time the results were reported. So in summary, for this particular example, assessment of c-Met inhibitor in patients with c-Met mutation demonstrated activity. Patients with c-Met mutation showed a greater tumor shrinkage than patients without evidence of c-Met activation. When activity is assessed based on dividing the patient population into 2 groups, with and without c-Met activation, the mechanism of action of this particular molecule was confirmed, and it demonstrated proof of concept by showing shrinkages and a slight improvement in progression-free survival. And with patient stratification into c-Met activation and lack of activation groups, PFS was evaluated, or could have been evaluated, was evaluated in this particular case, regardless of whether shrinkage was seen. And I guess one footnote is that if a placebo arm was added to such a study, again, a randomized controlled study with placebo, it would have allowed a more definitive confirmation of the improvement in PFS in terms of taking this compound forward into phase 3. So I'll now go to the second example, which is the proof of concept for sunitinib in imatinib refractory GIST patients. And here, the authors of that study learned from data from imatinib. So imatinib is a c-KIT receptor tyrosine kinase inhibitor and a PDGFR inhibitor. And it has been shown for imatinib that a decrease in the SUV max using FDG PET assessments is predictive of early and late stage responses to imatinib. And in this particular study, patients who had more than a 70% decrease in SUV max, as shown in that Kaplan-Meier curve with the blue line up at the top, had significantly better progression-free survival or time to progression compared to patients who had a less than 70% decrease in SUV max. And so essentially change in FDG PET SUV max was predictive of outcome in imatinib. And so I believe that the authors of the next study, the sunitinib study, which I will show here, used that information to design their proof of concept trial. In this study, they enrolled histologically confirmed GIST patients who had failed prior imatinib and were eligible for FDG PET assessment with an ECOG performance status of less than 2. A daily oral 50 milligram dose of sunitinib was administered for 4 weeks on, 2 weeks off, with 1 cycle constituting 6 weeks of treatment totally. Response biomarkers and safety were assessed. In terms of biomarkers, FDG was clearly assessed at the beginning of the study as well as at the end of cycle 1, and mutational analysis of KIT and PDGFR mutations was also evaluated in the study. So here is some interesting data. These authors classified their FDG PET response into 3 categories. Patients who had a greater than 25% decrease in SUV were considered to be MPRs. Patients who had their change in SUV within plus or minus 25% were considered to be M stable disease, and patients who had a greater than 25% increase in SUV were considered to be MPD. And FDG PET was totally assessed in 23 patients, of which 12 had MPR, 7 patients had MSD, and 4 patients had MPD. So when you look at the Kaplan-Meier curve on the right-hand side where progression-free survival was evaluated, and you look at patients with MPR using the FDG PET versus those patients with SD or PD on the FDG PET, patients with MPR had a significantly longer PFS compared to the other 2 groups. And that, again, was what one would have expected from the imatinib study. So it's a good example of how one could use data from the literature to design design robust proof of concept clinical trials to make decisions to go into late stage clinical trials. It's of note to add that KIT mutations, neither KIT mutations nor PDGFR mutations were predictive of PFS, OS, or clinical benefit, or of baseline SUV or change in SUV. And SUV decrease from baseline or residual SUV at 4 weeks post-dose was independently predictive in multivariate analysis. And so here is a quick summary. Assessment of PET at 4 weeks after sunitinib treatment helps distinguish patients who may benefit. So one could potentially select patients who are much more likely to benefit by sunitinib treatment. This is from the clinical perspective. And FDG PET seems to be a much better predictor of sunitinib benefit than mutational status in imatinib failures. Go to my last example, where I talk about the proof of mechanism, proof of concept evaluation of everolimus in a phase 1 study. Here is a cartoon which shows how the mTOR, PI3K, AKT, mTOR pathway looks like, and I've circled the particular proteins that were measured in the next clinical trial, which essentially turned out to be good biomarkers of this pathway. In this particular case, S6 kinase, EIF4B, and 4EBP1 were biomarkers in this particular study. I will show you the clinical design here. So this was a study in histologically confirmed advanced tumor patients, a standard phase 1 dose escalation study with 2 different schedules. A single weekly oral dose of 20, 50, or 70 milligram was administered, and in the continuous daily oral schedule, a dose of 5 or 10 milligram was administered in a dose escalating fashion. Pharmacokinetics was assessed, as well as safety and responses. In terms of biomarkers, biopsies were collected at baseline and at 4 weeks in the daily schedule and also in the weekly schedule. And protein levels of these epitopes that I mentioned earlier were assessed using immunohistochemistry assessments in tumor as well as skin biopsy specimens. Go to the next slide. It's a very busy slide, but I'll walk you quickly through it. So up at the top is a panel, a bar chart of the pharmacodynamic effect of everolimus in tumor samples, and below that is the pharmacodynamic effect in skin samples. Everolimus is an mTOR inhibitor which inhibits 4EBP1 phosphorylation and S6K signaling in tumor tissue, inhibiting proliferation of human tumor-derived cells. This is preclinical data. So when you look at the phase 1 study and you look at the levels of phospho S6, if you focus on the tumor bar chart up at the top, tumor phospho S6, tumor phospho EIF4G, and tumor phospho 4EBP1, all of those went down following administration of everolimus. Phospho-AKT levels in the tumor actually went up, and this is an area of now preclinical and potentially clinical investigation. And Ki-67, the proliferation index assessment biomarker, went down following everolimus administration. So treatment with everolimus resulted in an almost complete inhibition of phospho S6, phospho EIF4G, phospho 4EBP1, and one other marker. And AKT phosphorylation was increased in tumors. Cellular proliferation, as assessed by Ki-67, was reduced in both tumor and skin samples. More profound decreases in EIF4G and 4EBP1 phosphorylation was found at greater plasma exposures and greater with the daily schedule compared to the weekly schedule. So I'll summarize that study here quickly. Consistent with its mechanism, everolimus reduced the phosphorylation of S6, 4EBP1, and EIF4G in human tumor biopsies collected during the clinical trial. So that's essentially proof of mechanism. Phosphorylation of 4EBP1 was reduced more in the skin than in the tumor. Perhaps different compartments have different degrees of penetration of the drug. AKT phosphorylation increased, perhaps due to feedback mechanism, and this was discussed extensively at the last AACR meeting in April. Skin appeared to be a useful surrogate for tumor tissue for the mTOR pathway. Greater inhibition of phospho 4G at the 10 milligram daily dose and at greater than 50 milligram weekly dose was observed, and more profound inhibition was observed with the daily schedule. A greater decrease in phospho-EIF4G and 4-EBP1 was observed at higher exposures, and importantly, there was 1 PR and 3 stable disease for more than 5 months in this clinical trial, with 1 RCC patient who had a stable disease for greater than 14.6 months, which basically indicated that this compound sort of passed the proof of concept criteria, at least the way we use it within our organization. And as we know, everolimus is approved now in RCC patients who have failed sunitinib or sorafenib. So in summary of my presentation, I'll make 5 quick points. Adequately performed proof of concept studies to enable go-no-go decision making could significantly increase the probability of late-stage clinical success, and we have modeled this in terms of business case evaluations in our organization. Randomized controlled studies offer many design advantages over single-arm uncontrolled studies for assessing predictive biomarkers for cytostatic NMEs, and we believe that this is the only way to adequately assess the value of predictive biomarkers before taking them as an inclusion biomarker potentially in a phase 3 trial. For new molecular entities with a new mechanism of action, preclinical data can be translated by performing POC studies in patients with stratified grouped evaluations based on baseline biomarker status, such as that I showed you for the c-MET inhibitor. For follow-up compounds such as sunitinib in GIST, available information such as change in SUV of FDG PET for imatinib may help design a robust POC and enable decision-making to go into phase 3 clinical trials. And the pharmacodynamic effect of an NME on specified tumor targets combined with shrinkage or stable disease may help establish an early clinical proof of concept. So with that, I'll end my presentation. Thank you.